Hi class, and welcome to our first video lecture. I want to first thank you, as I know we didn't all sign up for online learning, and some of you may be new to it. I know I'm new to this, I guess, newer technology to me. But today we're going to talk about chapters 18 and 19, specifically the foot, ankle, and lower leg. So a little bit of overview for our class today. We'll be talking about the anatomy of the foot, ankle, and lower leg, and I know we're about 50-50 in our class on whether or not you've already taken anatomy, so hopefully this is a good review for some of you, and for others it's a good precursor to what you're going to get into. We're also going to talk about prevention of injuries. We know that that's one of the domains of athletic training. If we can prevent injuries from occurring, we're going to minimize any type of days lost for either sport or their activities of daily living. And then being able to recognize and manage specific pathologies of the foot, ankle, and lower leg, and how we're going to rehab them. The specific objectives of this class is to identify major functional and anatomical features of the foot, ankle, and low leg, figure out how we can prevent these injuries from even occurring and not clogging up the urgent cares and emergency departments, because foot, ankle, and lower leg injuries occur across the board, regardless of what sport you play or just stepping off the curb wrong. We will also explain the process of evaluating injuries. From some of our last lectures, you guys have already learned that we want to be methodical in our evaluation and not jumping around from different thing to different thing. That way we don't miss anything. Being able to identify specific injuries that occur in the foot, ankle, and lower leg, and then we're going to discuss plans for management. Depending on how severe, the patient may still be able to do some things, but may be a better idea to do non-weight bearing like a bike or aquatic therapy. And then design a rehab technique for each of those different injuries. So right now, I want you guys to go ahead and pause this video and take a second to think of different injuries that can and do occur in the foot, ankle, and lower leg. Okay, and with that, hopefully you've come across a couple of things. I know in the past I've talked, first I want to rule out any type of fracture or dislocation, and if those are clear, we'll go on to some of the soft tissues like sprains, strains. We'll talk a little bit about bursitis, Achilles tendonitis, plantar fasciitis, shin splints, things like that. Right now in our lectures where we would go and look at different videos, if you're a little squeamish, feel free to skip ahead. If not, I want you to pay attention and look at the different types of injury. What is the mechanism of injury? Is it an inversion ankle sprain or is it an eversion ankle sprain?
Some snaps on the sideline while offensive coordinators dream about drives like that. Orton steps up on the move, caught from behind and goes down at the 7-yard line. Orakpo made the stop.
When Orton gets up, he's walking a little gingerly. Again, credit the Redskins secondary. They made mistakes earlier. And that is a really awkward landing for Kyle Orton. Right, he gets that right and then the left. Both of his legs get caught underneath on that tackle.
Meanwhile, on the sideline, Chris
has gone on. Another example of the Warriors just aren't automatically switching as often as they used to. And I think that's better, especially with Cousins on the floor.
Durant is back in. He's doubled, and they knock it away. And KD's holding his right leg. Durant is holding his ankle. The Warriors had to commit a foul. He went down in distress right away.
Looks better now. Let's see how he manages to walk. Got a little limp there. Watch his right foot. Yep. Came down right on the side of the opponent's foot. And I think that was 8.
Steve Kerr's talking to him. Kevin's going to come out of the game. He's He's going right to the locker room.
I don't know whether it'll be back, but I'm glad it is.
So the interesting thing about those arenas is usually they at least have x-ray capabilities, and occasionally you will be able to take MRIs right then and there. That way the patients are able to determine, and the healthcare providers can make a decision on whether or not what exactly is going on, and if and when they can safely return to their sport without having any adverse issues affecting them. And a little bit of baseball compilations.
Lori, did he get there? He got tangled up around the bag and getting up as he went in.
Dallas, he throws it into center field. Stopping at second is Napoli, and he's hurt.
Going over second, not slide. Oh my gosh, second, not slide. Oh my gosh.
And Young ground ball off the chest of Freeman. Hudson got to the bag, and a collision. Hudson might have been stepped on. Hudson.
Ozuna cracks one to left, and it falls for a hit, and it kicks off for Franzen. Ozuna hustling, and touched the bag. This should be double right here. Oh, look at that right ankle.
Low throw, and Cespedes is out. No, hope he's not hurt.
See, he's been reluctant to slide it.
Oh, there's the turn right there. That's the turn. Little tapper that Lynn fields and throws wide, and he's hurt. He is down, and he is hurt.
Third base.
Oh, it's the ankle.
Yeah, you can see that throw.
Could happen here. That'll end the inning. Cargo went down. Is he all right? Grabbing him.
Yeah.
Back ankle.
A bunt on the third base line. Thatcher picks it up, has no play, and may have hurt himself.
So he might have got his cleat caught in this field turf, then rolled his, got his cleat caught in this field turf, then rolled his.
Red Sox third baseman. There goes Brock Holt. Pitch low. The throw is off target. And Brock Holt went into second base, and he's hurt immediately. Yeah, that left leg got caught on the bag. And
Just turned it all the way back. His ankle.
All right, and you guys are more than welcome to go and look and research and do some more video searching on different foot, ankle, and lower leg injuries. Right now we're going into the anatomy part of this lecture. Let me see if I can get my little drawing thing right here. Okay, so if we were to start right at the ankle, the head of the ankle, or I guess what would make up the ankle, is the tibia, which is your weight-bearing bone. Let me go over here to this next one, and I'll go back. Maybe not. Okay, just kidding. So, the tibia and fibula, which are the bones of the lower leg, it's on the next slide, connect or interact with the talus. This is the talar dome, which is probably one of the most difficult things to palpate. In order to palpate, you would have to have the patient in extreme plantar flexion. Okay, plantar flexion is if you were to put your toes into the sand, or like you're pressing the gas pedal to go really fast when you're driving. That is plantar flexion. Dorsiflexion is when you're bringing your foot up towards your head. And then if you do inversion, that's where the bottom part of your foot is rotating medially, and that would be inversion. And then when you go the opposite direction, when the bottom of your foot is going outward, that is eversion. Okay, so looking at the anatomy of the ankle, you've got your talus that connects to the calcaneus. The calcaneus, you might have heard it called the heel bone. Okay, and that's usually when we're walking, that's where we would have the heel strike first. When you go distally, you've got the navicular right here. I don't know if it'll, right here, the navicular. And just lateral to that is the cuboid bone. On the inside, you've got your cuneiform bones, which is either first, second, or third. And sometimes people will call that medial, intermediate, and lateral cuneiform. And then the long bones of the foot, you've got your metatarsals, which it goes 1 through 5. Starting medially to laterally. One of the things that we're worried about, or when we're palpating the foot, we want to go to the base of the fifth right here and make sure there's no point tenderness or anything, because there's a likely chance that you could have an avulsion fracture where the peroneal that attaches right there might pull off a chip of that bone. This is going to be really important when we also talk about taping, because we want to make sure that none of the tape would end right there on that base of the fifth. And then when we talk about our phalanges or our toes, the big toe only has 2 phalanges. Only has a proximal and a distal phalange, so they only have 2. And then on digits 2 through 5, we have a proximal. So remember our medical terminology, proximal where it's closer towards the foot, medial, and distal, meaning further away. All right, and here's the picture that I wanted to get, which are the bones of the lower leg. So over here on A, you have the anterior view, which is if you guys were looking at somebody from front on. The thicker bone is also known as a shin bone or the tibia, and the lateral bone is the fibula. It's a non-weight bearing bone. Some of the things that are, actually everything's important, right? But that I want to point out specifically is the tibial tuberosity. Let me see if I can draw. The tibial tuberosity. Right here where the patellar tendon attaches, and then towards the ankle, since we're talking about the foot, ankle, and lower leg, we've got the medial and lateral malleoli, where those are attachments of the ligaments that are commonly injured when there is a sprain of the ankle. And then you've got the interosseous tissue or membrane in between each that often is stressed and can cause issues, and you guys have probably heard of shin splints, which we will talk about later on. All right, now looking at the posterior aspect, hopefully you guys can tell this is a right ankle. You've got your tibia, which is more medial, and the fibula. You've got the talus and the calcaneus, which is where we're making our heel strike. And normally you would see the Achilles tendon that goes up to the gastrocnemius and the soleus. Okay, looking at the bottom of the foot, there are different arches of the foot. Okay, you've got the metatarsal arch, which is kind of like when in sports you're telling the athletes to get up on the balls of their feet. That would be more the metatarsal arch, right? On the distal part of the metatarsals, closer to the proximal part of the phalanges. The transverse arch, which we'll get into shortly, talking about if a patient has pes cavus, pes planus, meaning if they have a high arch or if they're flat-footed. You also, looking at this, the medial view, you've got the medial longitudinal arch, and then on the lateral aspect, it's the lateral longitudinal arch. Looking at the bottom, this is what I was talking about as far as the calcaneus going towards the metatarsal heads. You've got the plantar fascia I've talked before about plantar fasciitis, which is an inflammation of that plantar fascia. It tends to be more painful in the morning because throughout the night, muscles have a chance to cool down and shorten. And then most of the time when our alarm goes off, we get up and go, go, go. It's not like we take time to warm up and stretch. So putting and bearing weight on that particular foot that has that plantar fasciitis causes them a lot of pain. And then you've got your Achilles tendon that attaches to the calcaneus and goes up towards the gastroc and soleus. Okay, different ligaments of the foot. So, to your right, when we're looking at that medial view, there actually are 4 ligaments. Let me get my little drawing thing. There are 4 ligaments that are just distal to the medial malleoli, and collectively we're calling those the Sorry about that. Collectively we are calling these the deltoid ligament. On the lateral aspect of the foot, you have your anterior talofibular ligament, the calcaneofibular ligament, and then the posterior talofibular ligament. Collectively, those are the ones that are usually sprained when you have a lateral ankle sprain. All right, looking at the muscles of the foot and lower leg, this is looking from an anterior view. For a frame of reference, you've got the patella and the patellar tendon. You can see a little bit of the tibia right here, just I guess deeper from the tibia. You've got your soleus and the gastrocnemius, and then on the in number B, I guess, you have the tibialis anterior and the extensor hallucis brevis and longus. And each of those on the anterior portion of the lower leg are going to be responsible for dorsiflexion, so bringing that toe up. Okay, on the posterior aspect of the lower leg, down here on C, you've got the calcaneus that goes up to the Achilles tendon. The Achilles tendon goes up and attaches to the gastrocnemius. If you go over here to number D, letter D, they have cut away the gastroc, and just under that you've got the soleus. Right up here you've got the heads, the medial and lateral head of the gastroc. So that's why it's also important why we stretch not only the gastroc but the soleus. And how you would stretch would be bringing your toe up with the knee straight, and with that you're stretching the gastroc, and then if you put a slight bend in your knee, now you're stretching the soleus. Okay, so when we're walking, the foot serves as a shock absorber at heel strike and then adapts to uneven surfaces during the stance. So in the videos that we watched earlier, specifically the baseball ones where the base is not in line with just the flat surface, it's up above, that would be one of the uneven surfaces that's causing issues. At toe off, the foot serves as a rigid lever to provide propulsion force, so we end up moving forward. 80% of distance runners follow a heel strike pattern. Sprinters tend to be forefoot strikers, and that's one of the reasons when you look at a sprinter's shoes or their track spikes, all the spikes are at the distal portion of the foot, because they do have that forefoot striker ability. So with pronation, so remember when we have our hands in front of us and we pour that soup out, same thing with a foot. When the foot is more flat-footed, there is the subtalar joint where it has internal rotation of the tibia. So it might cause them to end up having a lateral ankle sprain. The subtalar joint is pronated for about 55 to 85% during the stance phase, and as the foot moves to toe off, the foot supinates, causing mid-tarsal joints to lock, and this allows the foot to produce greater force. Okay, so some of the things we're looking at right here is how that foot is in the weight bearing, so down at the bottom, and then in the non-weight bearing. Okay, where is the force? Is there a valgus force, meaning on the lateral aspect, putting a lot of pressure on that medial, or is there a varus force, which is opposite? Okay, and when you talk about pronation and supination of the foot, okay, excessive pronation, so think of flat-footed. They don't really have an arch. There's a lot of stress injuries that are caused by that. There could potentially be loose foot that allows more midfoot motion, and at the first digit, an attachment of the fibularis longus tendon. So it is hard for it to kind of provide more supination or have an arch for that rigid lever during the toe off. With excessive supination, so think of those that have really high arches, the foot is still rigid, but it decreases in mobility at the calcaneal cuboid joint. Okay, so on that medial side. What the heck am I saying? I hope I haven't lost you. So think of if you guys your foot's wet and you're making footprints across a tile or concrete. Okay, you should be able to see the toes and the calcaneus, and there should be just a little bit gone on that medial longitudinal line. If you can see the whole foot, then you have a flat foot or pes planus, or you have excessive pronation at the talar joint. Okay, if you only see the calcaneus, the toes, and the lateral aspect of the foot, then most likely you have pes cavus, or a high arch, or excessive supination. So hopefully that kind of makes sense to you guys. Feel free to email me with any questions, and I can further clarify. So how do we prevent foot injuries? A couple of different things we can do is make sure that our patients are wearing the correct shoe and that they're wearing the correct shoe size, okay? In general, and I can talk crap about it because I played soccer as well, soccer athletes like to buy their shoes too small because they want that leather to fit to their foot and to be able to feel the ball, okay? When you buy shoes that are either too big or too small, you run the risk of chafing or getting different blisters, and it's not the most pleasing thing to have occur. You can also have or get orthotics, okay, something that will correct any anomalies within your foot. And if you don't want to or can't go to a podiatrist, which is a foot doctor, one of the things that I would encourage our patients to do is to go to one of those like Dr. Scholl's places, either at Walmart or Walgreens, where you can kind of step onto the machine and it'll tell you what kind of foot you have and what you need to do to correct some of your mechanics. The best way to prevent any type of injuries is making sure they're wearing the appropriate footwear. And then if they have any type of biomechanic deficiencies, we can potentially correct those with orthotics. Ideally, it's best to see a podiatrist where they can do specific to your needs, but if you don't have that capability, you can do what I talked about earlier as far as the Dr. Scholl's inserts. And then also we want to make sure that they're paying attention to hygiene, making sure that they're not only washing their feet, but reducing the risk of, walking around in your sweaty socks or muddy socks or whatnot, because you can get what's called tinea pedis, which is basically like, I'm blanking on it. Not foot fungus, athlete's foot. Sorry about that, guys. Okay, as far as preventing injuries to the ankle and low leg, we want to make sure that they're warming up properly, that they're stretching, specifically that Achilles and gastroc, so like the stretch that I talked about before with the knee straight and with the knee bent. We also want to make sure that they're doing dynamic and static stretching so they can help prevent any type of injuries that can and do occur. Okay, some of the other things, and then we'll get into this either later this week or early next week, is doing prevention taping or orthotics. Okay, so a lot of times some of the coaches will require their athletes to either wear ankle tape or ankle braces, and there are pros and cons to each. So tape does provide some prophylactic protection, meaning preventative, but you run the risk of, if it's not put on properly, it can disrupt normal mechanical function and cause injury. It actually loses its elasticity after about 20 minutes. So in that case, it would be better to have ankle braces. I like ankle braces in that at a timeout or halftime, the athletes can take off whatever shoe attire they're wearing and retighten their ankle braces and not have any downtime, whereas you can't necessarily do that with the ankle taping. Bracing can impact ankle and knee biomechanics, and sometimes people will say that it causes them to have weak ankles. So one of the other things, besides just doing preventative taping and orthotics, we would have them be on an ankle strengthening program, and we're going to go into that in a little bit. Okay, when we're assessing a foot, ankle, or low leg injury, we're still going to go through HOPS or SOAP notes. So we want to ask questions. Basically, what was the mechanism of injury? Hopefully you were there to see, but we can't see everything, right? So what are our generic history questions? Okay, and then also specific to the foot. So where's the pain? Is it causing you pain all the time, even when you're sitting, or only when you're standing? Have you changed training surfaces? Maybe you were a track athlete and now you're doing cross country, where you're exposed to different rocks and pebbles or curbs and hills and whatnot. And then also, what type of footwear are you wearing? Does it increase or decrease the discomfort? And we want them to bring in the shoe attire that they're wearing for practice and sport, and then also educate them on what shoe attire to wear when they're not in sport. I've had volleyball athletes who had just sustained an ankle sprain, and then I see her in class and she's wearing wedges, which are a type of kind of high heel. Well, you run the risk of losing your proprioception and potentially rolling your ankle in that aspect. So we want to discourage that. So that was history. Observation. How is the patient walking? Do they have a pimp walk? Are they able to bear weight completely on it? Does the foot color change with weight bearing? So also, we need to make sure, I know right now it might be raining outside, but when we're inside, have them take off their socks. That way you can look at the different coloration of the foot, whether they're weight bearing or non-weight bearing. Are they flat-footed? Do they have a high arch? What is the foot alignment? Meaning, is it more angled? And is it equal and bilateral, or is it only one-sided? I find a lot of times with volleyball and the outside hitters, whatever side that they're landing on tends to be more inverted. And then, are there any structural deformities? Okay, going on to palpation. I palpate bony landmarks first. So I ask them where the pain is, and then I try and palpate the bony landmarks away from where the pain is, and then start going towards that area. Then I'll go towards the soft tissue. Again, away from where most of the pain is, finally towards where it's at, because I don't want to light them up when I first touch right where it's injured. And then pulses. We want to check the distal pulses. So if their shoe is still on at this time, it's going to be difficult in checking either cap refill or some of the pulses. If you are on field and doing this, maybe make sure there's no fracture or dislocation. Get them off to the sideline, and then you can end up determining what's going on from there. You can end up taking it off and check their pulses. So I want you guys to look up pictures of the posterior tibial and dorsal pedal pulse. Okay. This part in class is kind of where I would show you guys, and it's kind of hard to do on video. And then special test. For the foot, ankle, and low leg, the bony integrity test, there is a bump test and a squeeze test. And we have pictures and everything a little bit later on. But with the bump test, basically what you're doing is you're applying pressure with the foot, with the patient's foot in dorsiflexion, and you're hitting the bottom of the calcaneus. If that elicits pain in a particular part, in one specific spot, that would be a red flag, and it would be indicative of possible fracture. And then the squeeze test. So if they're having pain down at the ankle, I would start my squeeze test at just distal to the knee and squeeze the tibia and fibula together and then work my way down. If it's lighting them up and causing them pain when you're further away from the injury, it's still going to cause them pain when you get closer to. And again, that's a red flag. I'm going to send them out for x-rays. Okay, and then the soft tissue special tests, we've got the anterior drawer, the Taylor tilt, and the Thompson test. And again, I'll go over each of those in the individual slides. Okay, so this slide is the special test for bony integrity. Top left, let me see if I can have my little, okay, right up here, this is the squeeze test. If they're having pain down on the ankle, I would actually be squeezing up in here and then working my way down. Right here is the bump test. And like I said, you're just putting pressure on the calcaneus and giving them a hard knock. I do want to note, if they're wearing cleats of any sort, be cognizant of where those spikes are on the cleats. I have heard a horror story where somebody ended up doing a bump test on a baseball cleat, and they have metal kind of like slats, and the clinician ended up puncturing themselves. And then over here, this is the Thompson test, and it's testing the integrity of the Achilles. So on this one, you have the patient laying prone, their feet hanging off the edge of the table, and then you're squeezing the gastroc. And what that does, it should have a slight motion. I have no idea what I did. A slight motion at the Achilles where the toes of the foot would slightly flex. Okay, special test for the anterior drawer. So specifically, this test is looking at the anterior talofibular ligament and the other lateral ligaments. Okay, a positive occurs when the foot slides all the way forward and there's a clunking sound. So right here, let me go to the next one. This is the hand placement on the top left is the anterior drawer. So one hand is just placed distal on the patient's tibia and fibula, and the other hand, you're cupping the calcaneus and you're moving the calcaneus forward. There would be a potential clunk, or the patient would have pain right in this region, in that anterior talofibular ligament. Okay, moving back. Okay, the Taylor test, or the Taylor tilt test. So there's two different ones. One, you're moving the foot internally, or inversion, and with that inversion, you're testing the integrity of the lateral ligaments, and then also you're going to do an eversion, and you're testing the integrity of the deltoid ligaments. Both of these are done at 90 degrees. So when I go down here, and the bottom right is going to be the Taylor tilt for inversion. I particularly like having the same hand placement as the anterior drawer, where one of my hands would be, oh, that's not what I wanted to do, where one of the hands would be right here, holding the distal portion of the tibia and fibula, and then the other hand would be holding the calcaneus, and that way I'm not getting any type of mid-foot movement, and I can isolate either the lateral ligaments here for inversion or the deltoid ligament for eversion. All right, we're not going to do this since we're not in groups, but we would talk about different types of injuries to each of these, okay? One of which I will talk about is turf toe, okay? So turf toe is basically a sprain of the first metatarsal phalangeal joint. It got its name because in turf, usually there's not as much give as there is in grass and dirt. And when somebody gets into an athletic stance and it forces that first phalange into extension, it's causing a lot of pain. We will have a different taping that we will do for turf toe. And then I also wanted to bring up another video. You guys may have heard of Zach Miller. Let me pull that up. Okay, and here's Zach Miller, who is a football athlete.
Because he wants to throw it every down. 3rd and 10. Trubisky to the end zone. Touchdown, Zach Miller. 25-yard touchdown pass from Trubisky to Miller, and Miller is still down in the end zone. There's a trust factor, right? You see Zach Miller down in the end zone. Let's see if he finishes this catch. Left hand, hold the ball, still securing the ball. Absolutely. Now, the trust factor that I'm talking about is that Mitchell Trubisky trusts Zach Miller as he goes up and brings it in one hand. And what happens is Mitchell Trubisky throws to a spot. The biggest adjustment, you see his leg right there. The biggest adjustment Trubisky has to make is you throw a guy open. In other words, that's great coverage by Raphael Bush, but he throws to a spot. And hopefully Zach will be okay as we come back.
3rd touchdown of the year for Miller, but he is down right now. Zach Miller's on the cart, all of his teammates going over to him. We're not going to show you the replay.
The receiver lost control of the ball. The ball hit the ground.
Okay, and I realized that was a knee injury. I think I had added that to this PowerPoint because it had just occurred, so I apologize, but we'll get back to that when we have next week, or I guess the next video when we talk about the knee. Okay, some of the injuries that can and do occur. This was, I guess on the far left is a picture in your guys' book. You can't necessarily tell, but where that red circle is, it's the beginning of a stress fracture. So stress fractures take anywhere from 3 to 6 weeks to start showing up on an x-ray. And with that, if I suspect that, I usually hold off our patients on getting an x-ray, because if we get it too soon, they're going to be like, oh, nothing's wrong with you. And then they go back a couple weeks later, and sure enough, it was a stress fracture. The one in the middle and the one on the right is actually a football athlete who broke his tibia and fibula, and he caught a touchdown in the end zone, and the opponent had landed on him. So right back here, this is actually, I have no idea why I did that, sorry guys, but back there is a soft splint on him. He ended up having to have x-rays, and then he waited a couple of days, but they did end up having to go in and put some rods in both of those bones and put plates and pins in there. And this next picture is kind of, I guess, morbid also, so if it bothers you, please skip ahead. Some other injuries. These are both dislocations. The one on the left is actually an open dislocation of the first metatarsal phalangeal joint. How that occurred is we had some soccer athletes playing indoor soccer in a wrestling room barefoot. So another reason why we should never be barefoot. and they went to kick a ball, and the opponent had moved the ball away, and he ended up kicking one of those thick wrestling mats and ended up with an open dislocation. The one on the right is a softball athlete who was practicing for the first time on how to slide into bases, and her cleat got caught in the brand new turf, and she ended up not only dislocating but breaking her ankle also. I don't know if you can see in the top part of that picture, we have our vacuum splints. We were ready to vacuum splint her, but the EMTs were worried that I wouldn't get the vacuum splint back, and I don't think they were as comfortable with using those, so she ended up getting a cardboard splint. Okay, so those are some dislocations. A bursitis. So right here you've got more of the superficial calcaneal bursitis. So thinking of how you're going to fit that foot back into a cleat or regular shoe is going to be pretty painful. Okay. When you look at bursitis and you touch it, it kind of looks like a water balloon. Most patients say it doesn't bother them, except it limits their range of motion. This one would bother them because anytime you put your foot back into a shoe, it's going to be causing a lot of pressure and a lot of pain. So with this, we would have to have her wear flip-flops or Crocs or stuff without a back in order to let that kind of heal on its own. Okay, couple of other injuries. You've got heel contusions. So think of when people are doing plyometrics and maybe they're doing box jumps. Those box jumps, when they land, if they're landing too hard, they could end up bruising their calcaneus. There's a couple of different ways that we would end up treating it. One of which, over here under B, is a donut pad, where it's a foam pad and we cut a circle in it, thus the name donut pad. And what that does is when they put their foot in a shoe or a cleat or whatnot, it puts pressure around where the pain is, but alleviates that one specific part that has the pain. And then over here under A, there's a heel cup, which you can go out and purchase. That gives it a little bit of softer for, being able to bear weight and walk. The thing that I don't like about the heel cup is if you have it only on one side, now you end up with almost what feels like a leg length discrepancy and end up having hip and low back issues just because of the little bit of difference in, height, so to say. Okay, pes planus. This is what I was talking about, where the athlete doesn't really have any type of arch. So these are the people when you're walking around with a wet foot on the concrete, you see the whole entire foot. Okay, either they don't have a medial longitudinal arch, or it's weak or strained. They have calcaneal eversion and a bulging navicular, meaning that they might be more predisposed for an eversion ankle sprain. These are pes planus or flat foot. On the contrary, the other side is pes cavus or a high arch, where what we're worried about with that is these are the people when they're walking around with a wet foot on the concrete, you only see the toes, the heel, and maybe the lateral aspect of the foot. They don't really have any type of shock absorption, and they'll end up with foot pain. And then they have a lot of ball and heel foot pain. Okay, we also have Morton's toe, and basically what Morton's toe is when the second digit is longer than the first. And really it's nothing to do with the phalange itself, but it has to do with the metatarsal, meaning the first metatarsal is shorter than the second, and that's why it looks like it does. Okay, we also have different types of arch strains. Okay, there are 4 different arches. Each of those can be strained. You might have had an arch strain yourself. Maybe you've gone to Disneyland or another amusement park and walked around much more than normal, and you feel pain in the bottom of your foot. So that very well could have been an arch strain. It can be associated with the calcaneonavicular ligament, and there's just a lot of tenderness and swelling. Okay, when you have plantar fasciitis, that fascia on the bottom of your foot is swollen, how I talked about before, where it's more painful in the morning and because your muscles have a chance to shorten and cool down overnight. Well, this is what's called a night splint. This is a rigid splint, so if you're sleeping next to somebody or are a crazy sleeper, I wouldn't suggest this because you'd end up giving them bruises. There are other splints, meaning there's one specifically that's more of a sock that has a strap on by the toes, and that strap would go and Velcro around the proximal portion of the gastroc and put the patient into forced dorsiflexion. With plantar fasciitis, you can have heel spurs, fascia irritation, and bursitis. There is a lot of pain with that, and we need to work on maintaining stability of the foot and being able to brace that longitudinal arch. All right, Jones fractures. Okay. A fracture of the metatarsal can be inversion and plantar flexion, or what happens more often I see in my setting is athletes are stepped on by another athlete with cleats, and it puts a lot of pressure in one particular bone and causes a fracture. The most common one is at the base of the fifth, and you're going to have immediate swelling and pain right on that fifth. Okay, this is different than an avulsion fracture. So the Jones fracture is what we're talking about right here. An avulsion fracture would be right here, where it's just pulling off a chip of that. So I don't want you guys to get confused. Okay, you guys might have heard of bunions. Okay, bunions, or also known as a hallux valgus deformity, meaning there's lateral pressure, putting a lot of pressure on that medial aspect, specifically of the first metatarsal head. A lot of times people get this with shoes that are too narrowed, point, or that don't fit them. So think of ladies that wear stiletto shoes or cowboy boots that are not the square-toed, but more of the angled. So it puts a lot of pressure on there, and people end up needing to get a bunionectomy, meaning where they go in and surgically cut off part of that extra and realign that. Okay, bunionette is a bunion that unpacks the fifth. Okay. Okay, Morton's neuroma. Where are we at? There we go. Morton's neuroma is a thickening of the nerve sheath, specifically the plantar nerve, where it divides into the digital branches. So stereotypically, it happens between the third and fourth metatarsal heads, where that medial and lateral plantar nerve comes together, and the transverse arch of the foot is collapsed. And a lot of pronation can be a predisposing factor. So with that, how we can kind of affect that or elicit pain is either grabbing the end of a pen or the eraser end of a pencil and applying pressure between that third and fourth digit. If it elicits pain, that numbness and tingling, most likely it is Morton's neuroma. This picture shows a teardrop foam pad that you can put on their foot and hopefully alleviate some of that pressure to minimize that kind of numbness and tingling feeling that they can and do have. All right, and people can sprain their toes, just kind of like when you catch a basketball or any ball and you jam your fingers, you can sprain your toes. If you've ever kicked something, maybe walking around in the middle of the night and it's dark and you kick the bed frame or coffee table or any other type of non-yielding object, it causes a lot of pain. It could potentially push that toe beyond a normal range of motion and could potentially disrupt some of the ligaments. So it's going to cause pain and potentially swelling and bruising within 1 to 2 days. But if you kind of do a number on it, it can last even longer. So turf toe or hyperextension or sprain of the great toe, kind of what I talked about earlier, is it got its name from turf toe, like I said, because there's not a lot of give in that. And it's right here. So what we would do is, like any other sprain or strain, we're going to ice it, try and minimize any of the swelling so they can get their range of motion back. Most of the pain for them is going to be on push-off when they're walking, running, and jumping, which is definitely needed when you're doing sports. So it causes them a great deal of pain. There are rehabs that we can do, and then also a turf toe taping job that we'll get into shortly. Okay, fractures and dislocations of the phalanges. So dislocations are less common than fractures because most of the time we're wearing shoes or cleats or some type of protective equipment. The only time I've ever seen dislocations of the toe has always been when they're not wearing foot attire. I had a volleyball girl who was just peppering around before they were leaving in the gym, and she was wearing flip-flops and didn't want to put on her shoes, so she took them off and ended up running into something and dislocated her pinky toe. Same thing as the picture that I showed before where it was a soccer athlete kicking an unyielding object. They're going to have immediate and intense pain. Dislocations should be reduced by a physician, and buddy taping is usually sufficient. I know in the book it talks about casting might occur with great toe or multiple toe fractures, but speaking from my own experience, I've broken all of my toes at one point in time or another, not all at the same time, but really, you go to the doctor, they say, yeah, it's fractured, and there's not a whole lot that they can do for you except to tell you to buddy tape it. So, unfortunately, that is what it is. Okay, different types of toe injuries. You've got hammer toe, mallet toe, and claw toe. So, hammer toe is where there's a deformity, where there is a contracture where the interphalangeal or the PIP, proximal interphalangeal joint, is flexed. So look at letter A. That first PIP joint is completely flexed. B is very similar, except for it's at that DIP joint, the distal interphalangeal joint, where it's fixated. And then claw toe is a contracture of the distal interphalangeal joint, but hyperextension at that metatarsal phalangeal joint. Okay, so each of these can be where you're wearing shoes that aren't fitted properly for you. You don't have a big enough toe box, and it can definitely negatively affect you and affect your mechanics while you're running and doing other things. Okay, subungual hematoma. We see these pretty often in toes, I would say more so often in construction workers in their hands, and we're going to treat them both the same. It's basically like getting a blood blister underneath the toe. There's repetitive shearing forces on the toenail, and that blood blister underneath the toenail is going to cause them pain and potentially loss of the nail. There's a couple things that we can do to help fixate this. We can either use a cottering pen or a small Dremel, and with that I particularly would do more on the edge of the toe where we're just putting a hole into it, and we're slightly tapping the cauterizing pin until it goes through the skin, goes through the nail, and then ends up kind of cutting that blood blister, and then it'll come out through the nail. The reason I like doing it more distally is because it doesn't take as long for that to grow out, and you'll end up cutting it. If we end up cutting, and again, it depends on where that hematoma's at. If it's only down here, then that's where we have to do. But sometimes it'll cause those patients issues when they're taking off and on their socks, so I would just have them file that nail down right in that area. All right, ankle sprains. So the most common ankle sprain is inversion ankle sprains, and I talked to you guys about that before, where it's plantar flexion and inversion causes an injury to the lateral ligaments, specifically the anterior talofibular ligament. I do want to let you guys know there actually are 3 different types of sprains. The most common is inversion. It's about 85%. Eversion ankle sprains compromise about 5 to 10%, and it happens from everting the foot, and that deltoid ligament, or ligaments I should say, is stretched or contused. There is a third, which our book doesn't go into too much, but we will if you take PE 111, and that's a syndesmotic sprain. So this picture right here is showing an eversion ankle sprain. I don't know if you can tell, but the medial malleoli is right here. Okay, so all of this right here is just all swelling. I guess I should not draw. Okay. Ankle sprains, like in this, you've got the eversion ankle sprain where it's affecting the lateral ligaments, or the inversion ankle sprain that's affecting the lateral ligaments, or the eversion sprain that's affecting that deltoid or those medial ligaments. Okay, we also have the potential for somebody having an Achilles strain. It is very common in sports, and it happens when there's excessive dorsiflexion or tight gastroc and soleus. The pain can be mild to severe, and it can be either a partial or a complete rupture. I've only had a handful of patients with this, but all of them have told me that it felt like they were shot in their leg. None of them have ever been shot before, but that's just what they kind of explained that as. Looking at this, you guys can hopefully see the right Achilles is definitely much more red than the left, and more swollen. The tendon sheath can be affected and can lead to tendinosis. So the etiology of the Achilles rupture is where there's a sudden stop or forceful plantar flexion with the knee moving into full extension, but it usually happens more so to the kind of weakened warriors or those that are over 30 years old, but it can happen at any age, but more common than not, it happens those that are a little bit older. So a gastroc strain is going to be caused by a quick start or stop and jumping, and where the bruise is probably isn't where the actual strain is. I would surmise, because of gravity and everything, the actual strain is probably up here, and because of gravity, that swelling and bruising and discoloration has set in right there. So it's something to take note, and you will be able to feel when you're palpating a specific divot on them. Okay, you guys have probably heard of shin splints. Okay, it is actually called medial tibial stress syndrome, or MTSS, where you're going to have pain in that anterior portion of the shin. When we're talking about taping, we always ask the patient where the pain is, if it's more medial or lateral, because it's going to affect what way we tape them. Sometimes healthcare providers will use shin splints as a catch-all term for muscle strains, stress fractures, compartment syndrome, but it can and does account for 10 to 15% of running injuries, and it's that micro trauma. So think of all the jumping and running and on hard surfaces where you're causing that talus to kind of move upwardly and shift the tibia and fibula away. So you can have issues in that MTSS area with all of that. Okay, so we've gone over all of these different pathologies. How are we going to rehab those pathologies? One of my favorite ways of rehabbing is to make them non-weight bearing. So one of the things that we can do is put them on a bike or an elliptical, or if we had water in our pool, we could have them do an aquatic workout. Where it's a great workout, even though they don't feel like they're sweating, they are sweating because they're immersed in water. It's a great strengthening and ability for them to work on their flexibility. And with the strengthening, you're getting it in all directions because the water is encompassing them. Okay, looking on flexibility, there's different things we can do to help improve their range of motion. We can tell them to go take a yoga class, but more than likely, that's not going to happen. When we're stretching, we want to encourage them to make sure that they've warmed up before they've stretched. They can, manually stretch themselves. They can use a pro stretch or a slant board. The higher the angle of inclination, the more of a stretch they're going to have. Look at the difference between C and D. C has the knee straight, so that person's actually stretching their gastroc, and on D, with the knee bent, they're actually stretching their soleus. You can use a towel or anything else to be able to help work on that range of motion because it is very important. Now, as far as strengthening, there's a ton of different things that we can do to kind of strengthen, whether on A, we've got manual resistance exercises. This would require somebody else who knows what they're doing to be able to kind of give you an certain resistance, but still allowing you to move through the full range of motion. B has different TheraBand or TheraCord. And again, when we're talking about the foot, ankle, and lower leg, we want to make sure we're going through all the different planes and the 4 different motions. C, they're using a cuff weight, which, we have several different types, and you can work your way up because you don't want to just start, completely as this person is on D with full weight bearing. The picture that I've added to the right, we've got towel exercises. So I've already talked to you about marble exercises where it's working on those smaller intrinsic muscles. Same thing with these towel exercises. So what the person on top is doing is they're splaying their toes to be able to grab that towel and use their smaller muscles of their foot to kind of grab that and rotate it. To make it more difficult, we can put a weight on it to kind of make it worth their while and make it more difficult for them. A couple of other things with the range of motion. One of the things I would have somebody with plantar fasciitis or arch strains is rolling on rolling on a golf ball, or even better, freezing a water bottle and rolling on that. With that frozen water bottle, you're going to get the ice effect, the massage effect, and potentially somewhat of a stretching effect. The person on the right is actually using a BAPS board. The BAPS board, what they're doing is rotating either clockwise or counterclockwise, and there's a different size ball on the bottom. So the smaller the ball, the more the range of motion that we're working on. We can also have them do kind of toe taps where they're moving their toe in an anterior and posterior motion, and then also a medial and lateral motion to be able to do that. Some other kind of sports-specific things that we might get the athletes into, let me pull up this video, is more of a rehab phase.
Continuing on our progression with using Spark Motion to show athletes real-time feedback as well as create an exercise program and the foot solo, here we're dealing with the right ankle sprain. We progressed to more loading tolerance. And now we want to make sure that the athlete can properly decelerate. So we're going to have them jump, stick the landing, get back, stick the landing, get back. Just working on targeting with the dots, working on being able to control this, and then loading and unloading. Because again, if you can't stop and decelerate, then you have no business returning to play. Obviously, there's any number of progressions, but using the foot solo, one of the great things is that we can integrate in that jumping method by having the foot solo always return the ball to the head. So it's a strike, jump, land. We can start to just practice that concept. Notice we strike with the right, land on the right, and the foot solo keeps coming back up, or we can strike with the left and land with the right. So we can just create a program of striking, landing, and loading to mimic our progression.
Okay, so another exercise I would want you to do, everybody go ahead and stand up, as long as you don't have a foot, ankle, low leg issue. If you do, use the other one. Put your hands on your hips and lift one leg up. So you're going to be bearing weight or balancing on one leg. Okay, if that's super easy for you, and you're next to something that you're not going to run into or fall over on, go ahead and close your eyes now. So now that you close your eyes, you actually have changed your balance. What we're working on here is proprioception. Proprioception is your body's ability to know where it's at in space. So on some of those videos that you saw, like the pitcher who had caught the ball and went to go throw it, and he everted his foot and probably sprained his lateral ligaments and then fixed it. He was doing proprioception. So this is one of the exercises that we do with our athletes, and it's not only foot, ankle, and lower leg, but I also do it for knee and hip also. Okay, with that being said, we're done with chapters 18 and 19, foot, ankle, and lower leg. There is a really good article if you wanted further information on doing recovery work or rehab work on an ankle sprain. If you guys have any questions, feel free to email me and I will get back to you as soon as possible. Thank you and have a good one.